Welcome back again. Today we'll do the mock exam 2. The first case is about teaching CTG, and we will try to cover the new NICE guideline, which released almost 3 weeks, 1 month back. Dr. Amara will do teaching with me. I will be your role player. Take 2 minutes. If you are ready to start, we can start. Once you are ready,
we can start.
Okay. Start, my dear.
Hello, my name is Dr. Amara. I am ST5, and you?
I'm Hany, the ST1.
Nice to meet you, Hany. How you are doing?
I'm fine. Thank you very much.
So I think you are the one who want to learn more about CTG. Is that correct?
Actually, yes. The NICE guideline have released a new update for the CTG, and I feel that I'm a little bit confused about understanding it.
Okay, no problem, Hany. So we will try to do it together.
Thank you.
Any other problems you are having in this department? How is it going so far?
Everything is fine. Everybody's helpful.
Yeah, so you can approach any of us at any time.
Thank you.
So do you know anything about CTG? Have you seen it before?
Yeah, I did few CTG assessment, and I was competent about interpreting the previous guideline, but this amber, red, and yellow, I couldn't understand it.
Okay, so we will see how we can apply it to the new one and old one. We will compare it today. So, and in the end, I will give you the guideline, and I will give you the some more recent articles also, so you can study and make your knowledge more. So what is CTG? Basically, as you will be already knowing, it is a electronic trace of the fetal heart rate, and it tells us about its relationship with the contractions. So basically, we are doing this CTG to identify the fetuses who are at risk of hypoxia, so that we can do early intervention and we can deliver them if needed. Okay. There are few things we should always make sure once we are reading the CTG. There should be the name and NHS of number of the mother on the CTG. The date and time should be correct. And also the speed of the paper, it should be 1 centimeter per minute. Can you repeat any one of this for me?
Actually, this is a very important point. Thank you for highlight. It's a point of safety. I should check the patient name, the NHS number, the speed of the machine, and if any intrapartum event, I should document it in the CTG.
Yes, correct. So CTG is not indicated for all patients. If low risk, we can just do intermittent auscultation as we are doing. But if for high risk, like if the mother is having very high blood pressure, there is a suspicion that there is blood stain like a meconium, if there is maternal tachycardia of more than 120 on 2 occasions, or if the mother's temperature is 38 or more, or 37.5 on 2 occasions. So these are few of the things that will tell us we have to do the CTG in these cases. So for reading the CTG, we are using the mnemonic of Dr. C. Bravado. So for doctor stands for defined risk, as I told you. So these are the risks. We have to see why we are doing the CTG. Okay. And then we have the features of C. Bravado. Okay. First, they were doing it as reassuring, non-reassuring, and abnormal. So it is the same thing. So we will think about it as white, amber, and red. So white means normal, amber means it is coming in the middle zone, it is non-reassuring, we should be alert, and red means it is abnormal or non-reassuring. Okay. So we are assessing. So after doctor, it comes a C. C stands for contraction. So we should assess in 10 minutes how many contractions are there. So if it is less than 5, this is good. This is in the white zone. Okay. White. So in the previous one, we were calling it as reassuring. So it is the same. It is the white one. And previously, they were not putting this contraction there. And then it is the amber. For amber, it is if the contractions are more than 5 or more, or it is a sustained contraction hypertonus that lasts more than 2 minutes. Okay? Am I clear so far?
Yes, yeah.
So then we will assess the baseline rate. So first I will tell you the normal features so that you can absorb them, and then we will talk about the deviations from it. Okay. So baseline rate normal is 110 to 160. Anything above or below this, it will come in amber or red. Okay.
Okay.
So then comes V. V is the variability. So we are checking the beat to beat variability per minute. So between 5 to 25 is normal or white. Anything above or below, so we will see for how long it is, and then we will categorize it into amber and red. Okay. Am I clear so far?
Yes, yes.
So then comes the deceleration. Deceleration is the decrease in the heartbeat of the baby from 15 beats from the baseline for 15 seconds at least. Okay, so the decelerations also we have three types. It comes as early, variable, and late. So in this, early means early is usually it is the normal one. It is coming when the baby head is coming down. So early deceleration means it usually it usually peaks with the contraction, and the baby heart rate is recovered when the contraction is ending. Variable means there is no relationship to the contraction. So the baby heart rate drops without any relationship to the contraction. And late means like it is starting in from the after the peak of the contraction, and it is recovering after the end contraction is ended. Do you want me to repeat it, or are you getting it?
Oh, I get it. I got it. Thank you.
Okay. So anytime you want, you can tell me. I can repeat the things for you. I know it is confusing for you, so we can do it again also.
Thank you very much.
And then it comes the acceleration. Acceleration is a positive sign. It is increase in the fetal heart rate of more than 15 beats for more than 15 seconds.
Acceleration is
Sorry.
increase in the fetal heart 15 beats more than 15 seconds.
Yes.
And it's a positive sign.
So then based on these features, we will categorize overall. So if all features are white, that means this is a normal CTG. If one feature is amber, so it comes as suspicious for us. And if we have two amber or one red, it will come as pathological. Can you repeat it for me?
If all the features are within normal, white, this will be a normal CTG. If anyone came amber and the other all are white, this will be a suspicious CTG. And pathological, if two amber or one red.
Very good, Hany. You are very fast learner. Actually, I was fast. Still, you are picking very nicely.
Thank you very much. You have a very
So,
excellent way of teaching.
so Hany, now we can see this CTG. So, as we said earlier, so we have to see the name and NHS number. It is there.
Yes.
And we have to see why it is started. We can see it is due to 37 weeks due to IUGR baby. So can you tell me on this one, how many contractions are there?
Yeah, actually, I will count in 10 minutes. This is about 3 contractions.
Very good. So it will be which color?
It will be in the white color.
Yes, very good. And now what is the baseline rate?
Actually, I can see it's about 140.
Yes. So again, it will be in the white color because our baseline rate, it should be between 110 to 160. And
Yeah.
how is the variability for it?
The variability is within normal between 5 and 25.
Very good. And can you see any accelerations over here?
Actually, yes, there is about 2 or 3 acceleration, more than 15 for 15 seconds.
Yes. And is there any deceleration?
No, I couldn't find any deceleration in that CTG.
Excellent, Hany. You did very nice. So how we will categorize it? It will be a normal CTG.
Yeah, that's a normal CTG.
So now based on CTG, what we are going to do, if everything is normal, we have to see why we have started it. So since we have started it for IUGR baby, so we should do continuous CTG. We will tell the midwife to keep a look on the CTG. If any abnormality, they are going to inform us. And if there is any abnormality, so first we should start with conservative management, left lateral, stopping the oxytocin. And so usually with these measures, it improves. If not improving, you should always inform your senior and they will teach you further. Okay.
Okay.
So how did the session go?
Actually, I understand a lot of you. Thank you very much. You did very well.
Okay. So these are few articles. You can read this and we will arrange another session. Anything I can do to improve my teaching?
Just keep like this. Your empathy and your way of teaching is excellent. Thank you very much.
Thank you.
Well done, my dear. Well done. Actually, I did this task in my exam. It's a long task. Otherwise, you have the approach. If you start teaching all the nice guideline, you will not finish in the time. First of all, I will give you a feedback about your introduction. Your introduction was very excellent. You approached the task very nice. First of all, you exclude that I don't have any problem in the department, and this can be a bullying. Actually, in the online exam, you will have no bullying. If anybody dealing with me or misbehaving with me, this will be in the face-to-face, not in the online exam. Your introduction was very nice. You set the agenda, why you want to know, what do you want to know, and checked my background. Are you aware about the previous guidelines? So you will update me. You will use my previous knowledge and update it with the new topic. And that was lovely, actually. And let's see how to discuss. Definition. You started by what is CTG? CTG is an electronic fetal heart, which we check the baby movement and how it's doing with regards to the contraction, in relation to the contraction. We can check by, there is alternative by a stethoscope or a Doppler, and we are not doing CTG for any cases, except there is a reason to check if there is a baby hypoxic or the baby needs to interfere. So there is indication to do the CTG, and you highlighted this. Before starting the CTG, this is all the safety point, and you addressed all this. There is some parameters which you should do. First of all, the speed of the paper should be 1 centimeter per minute, and the paper should moving freely. The machine should be checked for the correct time and date. Otherwise, you will have no medical legal documentation. Any interpretation, any intrapartum event, any PV, any left lateral position, any vaginal examination, any epidural should be documented in the CTG. An arrow from down, and you will write that this PV done or left lateral position done. The patient should be in the left lateral position, and the CTG should be labeled by the patient name, age, and HS number. All these are star point in safety. These are a very important point in safety. Can you repeat? And you did this. What is the indication? Classify it into two, maternal and fetal. Maternal, like a previous scar, maternal tachycardia, fever, 38 once or 37.5 twice, any sepsis, any abnormal pain, a lot of maternal indication, hypertension, diabetes type 1, rupture membrane for more than 24 hours, prolonged first stage, oxytocin use, previous CS, and for the baby, if there is malpresentation, breech, transverse, oblique, IUGR, like our task, multiple pregnancy, twins, small for gestational age, anhydramnios or polyhydramnios. These are some of the indication. If there is significant meconium, this is an indication for continuous CTG. What is the benefit from CTG? Why? Actually, there is an advantage. It have a good sensitivity in predicting the neonatal outcome and decrease the neonatal scissors. But there is a lot of advantage as well. The disadvantage that you are focusing on the baby and the mother is out of your scope. It's having a high false positive rate, although decrease the neonatal scissor, but there is no difference in the cerebral flow palsy in the long term. Possibility that the woman not in the center of the care, the baby having the priority, and this is should not be done. The CTG was also associated with an increased number of cesarean section and instrumental births because of the mother worrying and increased intervention. Continuous CTG also makes moving of the woman in the labor ward challenging, and she will be tied. In that scenario, she will be tied, kept tight in the bed, and in that scenario, you may need to offer a telemetry. We can offer a telemetry if the woman wants to go to the pool. There is many variation in the interpretation of the CTG. That's why you need to follow or stick to the guideline. Chorioamnitis can change the interpretation of the CTG. Usually, we follow a systematic approach to comment on the CTG, and that's the C bravado. First of all, the Dr. C bravado is a good approach to follow. DR determines the risk, and you can remember this by the name or the mnemonic of mothers. Mothers, the risk may be the baby, like meconium stained liquors, oxytocin use or no, temperature, high or no, hemorrhage, hypertension, hyperstimulation, the rate or number of contraction, the progress, and if there is rupture of membrane, and the scar, if there is previous scar, and if the baby is breech or other malpresentation. These are the risk factors, which mainly the indication for the mother or the baby. So that determines the risk before delivery. The CTG is not necessary for every patient, except there is a high risk. A low risk patient does not need. I will use intermittent auscultation. Contraction, the pattern of the contraction, the duration, the frequency of the uterine contraction, it should be less than 5 in 10 minutes. And this will be coded as a white, normal. If it is more than 5, this will be amber. The baseline rate or the variability, as you said, it will be between 110 to 160. This will be in the normal. If it is below this, between 100 and 109, this will be amber. If it is below 100, it will be red. And the same, if it is above 160, this will be amber or red. Variability between 5 and 25, this is the white zone. If it is less than 5 for 30 to 50 minutes, this will be in the amber zone. If it is more than this, more than 50 minutes, this will be in the red zone. And there is a change here. It was before 25 to 25. They changed it. Less than 25 or more than 25. So the variability, 25 minutes or 25 beats per minute, over 10 minutes only, less than 10 minutes will be amber. This is a change. It was 25 minutes before. And more than 10 minutes, this will be red. The change in variability. Acceleration, you said it's a good reassuring sign or a positive sign. More than 15, over 15. More than 15 beats, over 15 seconds. The presence of acceleration in a reduced variability is a good positive sign that the baby is healthy. But absence does not indicate anything, does not indicate fetal acidosis. That's why it's a positive sign. Deceleration, and you said fall in 15 minutes, less for 15 beats per 15 beats over 15 seconds. And there is 3 types: early, late, and variable. The early, which is mirroring to the contraction. The late, which comes after the contraction. And variable, which is a V shape. There is some concerning character which happened in the D cells if you have loss of shoulder before and after the D cells, loss of variability in the D cells, or going back to a lower baseline or does not recover to the baseline. These are the non-reassuring signs. The overall assessment, what is the categorization of the CTG? If everything is fine, it will be normal. If one only amber suspicious, if 2 amber or 1 red, this will be pathological. So normal CTG means all the features are white. Suspicious CTG, which is 1 amber and the other 2 is white, or the other 3 is white. Pathological, which if you have 1 red or 2 amber. What is the action? Like you have here, our CTG. Let's have a look in this CTG, as you did. First, convert the patient name and the H number on the CTG. If you didn't do, you will lose a safety point, because this is a very important name to teach him on hands safety. So this is the first safety point. Then let him to speak, as you did. Actually, you did it very nice. And we should ask about the CTG history, why it is done, if there is any medical, surgical, if there is any antenatal problem. I should do examination for the mother to see how she fared in the delivery, abdominal examination and vaginal examination, to see if there is any problem. To comment in this CTG, you should see the contraction, the baseline rate, the variability, the presence or absence of deceleration, and the presence of acceleration is a good sign. This CTG is normal. Can you tell me what is the baseline? What is the parameter? What is the variability? What is the deceleration? Is there is any contraction? How many contraction in 10 minutes? So the woman will be hydrated, ampulated. I will continue the normal care according to the partogram in the first stage or in the second stage. A very important safety point. So let's see other parameters. Is there is any meconium? Is there is any fever? Is there is any advanced? What was the PV of the patient? How far this woman in labor? And after that we will take an action according to the CTG. If it is normal, so we will continue the normal care. First, if the mother inform the mother about that the CTG is normal, keep her well hydrated and ampulated. If the CTG is fine, she can ampulate, she can have a walk. Routine assessment and documentation according to the partogram, and the decision making will be not according to the CTG alone. It should be according to the overall assessment of the mother. If there is any risk factors, if there is any delay in the labor, what will be the PV assessment, and what is the CTG finding? So an overall assessment. Fetal movement, progressive labor, maternal wishes. The baby have no autonomy until delivery, so keep your eye on the mother, not on the baby. If the CTG is normal, continue the normal care. If we started because of concern arising the intermittent auscultation, we can refer the woman, if the CTG is normal, to the intermittent auscultation again, unless the mother requests to continue. Suspicious, so you will do one of the conservative maneuver, left lateral position, oral or IV fluid. Take care if the woman have hypotension, stop oxytocin or give consider tocolysis. If the CTG pathological, offer fetal scalp stimulation. They put a concern, actually in the new NICE guidelines, they put a concern about the fetal scalp stimulation. It will if the CTG improved, so you will expedite the if the CTG improved, you will continue the normal care. If the CTG does not improve, you will expedite the birth either by operative vaginal delivery or cesarean section, and they put a concern about the fetal blood sampling, as the RCOG was doing the strategy, and the RCOG said that the UK practice saying that the fetal blood sampling mostly it will be a time loss. So they put a concern about the fetal blood sampling, and they hold the recommendation to do a fetal blood sampling. So fetal scalp stimulation, improve, continue, not improved, expedite the birth. This will be in case of he gave you a normal CTG or a pathological CTG or a suspicious CTG. So you need to address what is in front of you. Is it normal? Is it suspicious? Or is it pathological? Okay. He may change. I will give you. I will give you some of the CTG in the unit or the unit protocol, and I will give you these articles, or I will give you the e-learning of the RCOG, the strategy module, so you can have a look. I make it in a summary. This is my summary or my gift for you. The features, the white, the amber, and the red. In one case, take a screenshot and print it for the exam. The contraction, less than 5 contraction in 10 minutes, this will be white. 5 or more, this will be amber, and no red for the contraction. So I addressed the first problem in one line. The baseline heart rate, 110 to 160, normal, white. If it is increased 20 beats from the baseline, this will be amber. So it started at 120 and became 140. This is amber. Started at 110 and became 130. This is amber, even in the normal range. If it is between 100 to 109, amber. Or you cannot find a baseline. It's called saltatory CTG like this. More than 25. The variability is very high. So you cannot determine a baseline. There is no baseline. This will be amber. Below 100 or more than 160, this is red. There is a change here. This was until 180, non-reassuring, and above 180, it was abnormal feature. So there is a change here. Take care. 160 itself, it will be red. Above 160, it will be red. 160 itself, white. The variability between 5 and 25, this is the normal. So you are in the white zone. Less than 5 for 50, amber. 25 for 10, and this is a change. It was 25 for 25. So less than 5 for 50 minutes, this is amber. 25 for 10 minutes, this is amber. If it exceeds this, this will be red. Less than 5 for more than 50, or 25, more than 25 for more than 10. This will be a red. And sinusoidal, which is the fetal anemia. The deceleration, to comment on the deceleration, either it should be absent, no deceleration, or early deceleration, or variable without the concerning character. What is the concerning character? This is a D cells, variable D cells. Loss of shoulder, no hyperactivity or no acceleration before the D cells, and no acceleration after. This is called shoulder, a concerning character. If these shoulder are not there, this is a concerning character. Loss of variability in the D cells, concerning character. Recovering to a lower baseline, a concerning character. Or does not recover, a concerning character. So variable deceleration without any of these, this will be only in the white zone, a variable with no concerning character. If it is repetitive, repetitive itself means more than 50% of the contraction have the deceleration. So 50% of the contraction contain variable D cells, repetitive variable, with any concerning character for less than 30 minutes. So multiple variable D cells with concerning characters for less than 30 minutes, amber. Variable with any concerning characters for more than 30 minutes, this will be amber. Repetitive, late, less than 30 minutes. So repetitive variable with any concerning character, less than 30 minutes. Or variable with any concern, variable not with each contraction, less than 50%. For 30 minutes, this will be amber. Repetitive, late, for less than 30 minutes will be amber. More than 30 minutes will be red. Repetitive variable with any concerning for more than 30. Or late for more than 30, or acute bradycardia for 3 minutes or more. So the same parameter will change if it is less than 30 or more than 30. Late, less than 30, amber. More than 30, red. Repetitive variable, less than 30, amber. More than 30, red. This is the summary. And acute bradycardia not recovering for 3 minutes or more. This will be a red color. If you have 2 amber or 1 red, this will be a pathological. Categorization. I will depend on 4 features: the contraction, the baseline rate, the variability, and the D cells. Normal if 4 parameters are white. Suspicious if 1 is amber. Any of these is amber. Pathological if 1 feature is red, or 2 or more feature is amber. This is the new classification. My dear candidate, it is not for you to, in the exam, to teach him all the nice guideline. You will not have 10 minutes. You need 30 minutes to do this. Okay? Communication, you need to check learning, check understanding, what is the background, and appreciate. You are a good learner, you are a fast learner. The patient safety here in that scenario, before starting the CTG, ensure the patient name, age. It's a medical legal document. It can be in the court. You should keep it for 25 years if it is normal, and more than 20 indefinitely, if it is abnormal. Check the risk factor of the patient. Information gathering, check the background. If there is bullying or no, what he understand before or no. What are information he need to know. Applied clinical knowledge will be about the indication of the CTG, the contraindication or the benefit and the drawbacks, the definition, the management plan according to the CTG. In my exam, it was normal CTG. In other exam, he may give you suspicious or pathological. So the action will depend on in front of you. And how you will guide the trainee to answer his concern. Don't give too much knowledge. Give it a chunks and ask. Chunks and ask. About the CTG, follow this template, or you need to approach as what we have done. Take care about the trainee agenda. Ask him if you have any problem, if you have any concern in the department. Be aware about the polling. It will not be for your exam, for the online. It can be in the face-to-face, as it came before in the teaching note tie or teaching preach. It came as a polling station, not as a teaching task. You should check the understanding at least twice and ask him to repeat what you have said. At the end, ask him about the feedback and give him the nice guideline, give him the e-learning, the Strat OG module, or the basic practical skills, so you have covered. How to check the variability? It will be 1 minute to check the lower part and the upper part in 1 minute. In 1 minute. This is according to the machine. This may be 5 minutes and this may be 10 minutes. According to the machine, 1 centimeter in 1 minute. This will be how to adjust the machine. This period of reduced variability and this period is a good variability between 5 and 25. This is the baseline, 140 up to 160 is normal variability, from 5 to 25, 165. This is the D cells. This is variable D cells. Why? It's a V shape. This is a shoulder. The shoulder acceleration before and after. And this is the V shape variable D cells with variability in the D cells. Concerning character, if this absent, if it does not recover or continue in a lower pace, all these are concerning character. So this is a variable D cells. I will count if there is any concerning or variable D cells itself without any concern for 30 minutes. This is 20 minutes. So until now, this CTG is normal. It should exceed 30 minutes to be 1 ampere, which is suspicious. Okay. Variable D cells, it should be for 30 minutes if no concerning characters. Again, this is a variable D cells with no concerning. There is deceleration, there is shouldering, there is acceleration, and the contraction is 5 or 4 in 10 minutes. So this is a variable D cell. Until now, this is 20 minutes. So until it's a normal CTG. This is a pathological CTG. Why? Sinusoidal pattern. This is, can anybody tell me this is pathological or suspicious CTG? Classify the D cells. What is this? And is it pathological or suspicious? According to what? This is a late.
Like they seems to be late because they're coming after the contractions.
Yes.
First, and so now we need to see if it is in the 30 minutes or if it is less than 30 minutes, then it would be suspicious.
So this
and
is
if it is
repetitive. Excellent. This is repetitive, late or late with each contraction. So I need to see the 30 minutes. Is this trace 30 minutes?
No, it is not.
It's
1, 2,
is.
yes, 30 minutes. Yes, it is.
It's 30 minutes. So this is pathological.
Okay.
Late, repetitive for 30 minutes or more than 30 minutes. So this will be pathological CTG according to the new classification. What will be the action? You will do the resuscitative maneuver, the conservative measures, fetal scalp stimulation, then expedite the delivery. Fetal blood sampling is a time loss. Clear?
What can you please just show the slide of variable decelerations?
Variable deceleration, the concerning characters. You see here, this is the variable D cells. And what is the concerning character? The variable will be a V shape. Shoulders means acceleration before and after. Okay?
Okay.
Variability in the D cells is not a concerning character. If it is absent, means this is a concerning character. If does not recover to the normal baseline, this is a concerning character. If recovers to a lower baseline or does not recover, this is a concerning character. Okay, this is how to understand the CTG. Any query?